perfect. Thank you.
Okay, awesome. So we're gonna present the second case of another pituitary tumor. This is the multidisciplinary team at the Mayo Clinic, including Dr. Quinones, Dr. De Almeida, and Dr. Lee from neurosurgery, Dr. Sampson and Dr. Burnett from endocrinology, and Dr. Donaldson from ENT. Yeah.
Okay, so this is a 61-year-old man who presented with a 10-year history of difficulty losing weight, hair loss, muscle atrophy, decreased libido, fatigue, and loss of morning erections. He had a past medical history of obesity, prediabetes, and he didn't have a gallbladder. It was congenital and hypogonadism. He was actually already on testosterone replacement when he came to see us. His BMI was 42.9, and really the only other pertinent thing was that he had some dry skin. If we go to the next slide. Looking at his labs, so his baseline cortisol was 21. It looked like his IGF-1 was 86, and TSH was 2.95, but then he originally came for just a hypogonadism workup. So it was found in general endocrine clinic. So the FSH and LH were very suppressed. This was also because he was on testosterone, but his prolactin was 771. So his testosterone levels were 342 and 10.9 on 100 milligrams of injectable testosterone twice a month. So every 2 weeks he was doing that. Prior to this, though, he had labs done with his primary care provider, and his testosterone level was 18 at the time. So it was really low, and he'd already started on replacement and then was seen here like several months later. But that prolactin was incredibly high. So then he got an MRI of the pituitary because of that.
Yeah, so this is the MRI of the pituitary. Here on the right, you'll see the T1 plus contrast, and on the left, you're gonna see the T2 sequence of a coronal view of the sella. So I'm gonna scroll through the T2 first, and you can see in the sella region a lesion on the right side, on the right aspect of the sella, right along the cavernous sinus on that side, and about in the the cavernous carotid. On that side, the stalk is deviated to the left, and the normal pituitary is here on the left. Here on the T1 postgadolinium, you can see the same lesion. So it is minimally hyperintense on T2, and it is contrast enhancing on T1 postgadolinium here. And you can see the lesion towards the right of the sella and towards the right cavernous sinus. Dr. Vibhuti, do you have any additional comments here?
No, not really. I mean, it's not invading this cavernous sinus as yet. You can see it's little insinuating above that. So most likely it's not crossing the carotid or encasing it. So it's just insinuating it. Yeah.
In close relationship there. So at this point, the difference.
Maybe one quick comment right there, because I think that Prasanna mentioned something very, very important, which makes a huge difference for us, is that he doesn't think that is invading the cavernous sinus. And I also felt that way. And I, at first, when I saw this, I told Susan, this is a cheap chat. We can get it out. But we're about to see another MRI right before the surgery that it gets a little bit more complex. And I'll be interested to see what Prasanna thinks about that. But at this point, I'm telling Susan, we got this. We're ready to rock and roll. There's going to be a cheap chat. We're on it.
Yes, sir.
If I may just add one comment to that, if you can go back that one slide. Hello, everybody. JP Almeida here. One thing that, looking in retrospect, if we look at those images and if we look at the component of the tumor and its relationship with this ascending segment of the cavernous carotid, and if you scroll back and you look right at behind this ascending segment, you're going to see that there is, so in the way back, yeah, then there, right there, if you were to stop, not even there, like right there where the arrow was right now, that's kind of going towards the Joelis canal and like in the posterior part of the cavernous sinus, which to me, like looking now in retrospect would help us to look at that, although the tumor does not extend lateral to the intercarotid line, that there is a potential invasion of the cavernous sinus. And the other thing, if you look at the roof of the cavernous sinus on the left side, which is the normal side, and compared to the roof of the cavernous sinus on the normal side of the T2 especially, you would see that you can't really differentiate. It seems that the roof of the cavernous sinus is all intact, right there. If you stop right, yeah, in that image, if compared to the other side, it's kind of like if you just can't tell. So one would look at this and see, well, I mean, I cannot really tell where potentially the medial wall was. So I think that's another thing that should point us to, well, maybe there's a chance that this is going to be in the sinus as well. Anyways, just some comments. Thank you.
But I saw Susan, Dr. Sampson, you were about to say something too.
Well, I'm nodding to myself because, I say I'm very not endocrinology when it comes to prolactinomas. If I have very good surgeons, the patients don't tolerate the medication, which this patient did not.
Spoiler alert.
Yeah.
You muted yourself, Dr. Sampson. Oh.
No, that was all I was going to say. I do want to comment also. One of the biggest mistakes we make as endocrinologists or even primary care is we have to remember that if you start someone on cabergoline and you don't have control of that tumor and you add sex hormones, so you add testosterone injections, some of which can be aromatized in the tumor to estrogen and drives prolactin, you may find that you have more resistance to cabergoline treatment. So you want to make sure you have control of that prolactin and normalization and that you're seeing tumor shrinkage before you start sex hormones, because that leads to a little more difficulties when you're dealing with trying to normalize things.
Thank you very much. So at this point, the differential diagnosis was pretty clear. It was a prolactin secreted pre-term carcinoma with a symptomatic improper anemia with a prolactin level of 771 and evidence of a cellular lesion on imaging. The other differential diagnoses were really low in the differential.
So he was started on 0.5 milligrams of cabergoline twice a week for 1 week, and then increased to 1 milligram twice a week. But at his 1 month follow-up, he was having a lot of symptoms. So he was having a lot of nausea, extreme variations in motion, hypersexuality. He was having like fireworks kind of in his eyes. So he really didn't tolerate the cabergoline at all well. And he's even at talking to him in the hospital, he was like, that was a horrible medication. I did not want to be on it, etc. We can look to the next slides. He did get some follow-up labs though during that time period, and it looked like his prolactin had come down quite a bit. It was 48. So this was 3 months after. And he was, I think we all know, he went to surgery after holding the cabergoline. So we can keep going.
Yes, this is the post-op MRI.
I'm sorry.
And I was going to ask Dr. Patel, was there, are these known side effects of the medication, the ones that you listed right there? Is that, I know nausea and vomiting and things like that, but the other ones, are they reported?
I know that there's like mood changes that can happen with it too. And he did say that he was getting like depressed. I'm not sure about the hypersexuality. I don't know, Dr. Sampson, if you've seen that before.
So we're learning more and more about cabergoline as a dopamine agonist. It also binds dopamine 3 receptors and can activate impulse control disorders, including gambling, spending, punding, hypersexuality. There's also something you have to warn your patients. If he's had testosterone of 18 for a long time, and now he has a testosterone of 400 or 500, and he's on CAB, there is also an aspect of those very broad changes in androgens that could also have an impact as well. So it might be hard to tease that out in his case. But yes, we do have concerns about impulse control disorders on cabergoline.
Thank you. Amazing. Great teaching.
This is the follow-up MRI. Yeah, this is the follow-up MRI where you can see the marked decrease in size on the lesion on the right side there. And this is the MRI where Dr. Q is saying that you can see it, you can't really see if it's invading or not the cavernous sinus. Dr. Vibhuti, did you have any comments here?
Typically, when I look at this, there is something, I don't know whether you heard of this NOS classification or grading system for intracavernous sinus invasion, where all of you are aware of these carotid artery landmarks which you use, the medial line going through the medial carotid artery wall, then the intercarotid line or the median line, and the lateral line which goes through the lateral wall. And use these 3 lines to grade the invasion of the carotid cavernous sinus. So okay, basically grade 0 is the line, the tumor is medial to the line, and grade 1 is, it is still not past the intercarotid line. Grade 2 is past the intercarotid line, but still not beyond the lateral line. So the grade 1 and 2 tumors, typically we consider non-invasive, but still in grade 2, you could get, there are reports which say that up to 8 to 10% of patients could have surgical invasion of the sinus in grade 2. That is, even though they are not past the lateral carotid line. And once they pass the lateral carotid line, then you say there is higher chance of grade in invasion, especially if it is below the cavernous carotid artery, if it goes below the cavernous carotid artery. So here what I felt was that, if you look at this, you can see along the lateral margin of the tumor, there is this dot with a circular CSF around it. And that's the third nerve. See that go up above the carotid? Yeah, that's the third nerve with a cistern around it. And what I see is that there's a beautifully preserved wall of the, between the tumor and the third nerve cistern. So I felt the dura is intact, and at least on the MRI, I don't feel inclined that it's invading the cavernous sinus based on these images.
Okay.
I felt differently. I was like, at this point when I saw this, I was like, man, this is in the cavernous sinus. Just looking, I tell you what my impression is. It's just the big picture after being there so many times, Prasanna, is that the amount of tumor is there. The pituitary is so thin on that side. It's towards the right-hand side. It's pushed a little bit, but not too much. I would expect it that, if it was truly not in the cavernous sinus, this tumor would be pushing the pituitary a lot more, even as small as it is. So, and that midline shift is not as prominent. So I'm thinking to myself, this one is into the cavernous sinus. This is going to be a more complex, and also the second thing that worries me is the fact that there's tons of CSF. As you can see, Ricardo has it right on the T2. He's pointing right there with arrow. I mean, I'm thinking to myself, I have a very thin dura. We need to get on the side of the pituitary, not necessarily normally we go into the pituitary fossa and we go laterally to these tumors. I said, in this case, we need to come in from laterally to medial. Otherwise, we're going to have a world of hurt CSF leak and we're not going to cure this man. So this went from what I thought it was going to be a cheap chat to a lot more complex type of case. And also at this point, I think the day before, the surgery, we also knew that his prolactin had gone up to about 500 or something like that.
A quick comment on prolactinomas. I've seen this not uncommon with prolactinomas. They tend to be very soft tumors, at least based on what I never felt them. So you guys need to tell me. But they can be aggressive looking. They can invade the skull base. They can be very vascular. And, I've seen prolactinomas going crazy. And somehow they, quite often, actually not often I would say, but once in a while, you'll see this appearance where the CSF is preserved in the center and the prolactinoma is growing like crazy laterally. But that's what, the prolactinomas probably do sometimes.
Well, we'll see what we found, but Dr. Monteser, go ahead. Susan, I want you to realize that you have two people who have spent 2 years of fellowship. That Ala, spent time with Dr. Luss, 2 years working with him. And JP has spent time with the people in Ohio and then in Toronto. So you got a lot of interest here in pituitary. Go ahead, Ala, please.
Thank you. So I really appreciate this wonderful discussion about this lesion and the extent of whether it's invading the cavernous sinus or no, and spend that time in detailing the MRI. It's just one thing that I noticed on the coronal view, the Boscon on the right. If you scroll a little bit, more. There you go. Yes, this one, or maybe a little bit more if you can. Okay, let me go back, please. So the adenoma is right there, inferior to the carotid, and it's kind of like insinuating itself within the inferior angle, the carotid cavernous venous angle right there. That has a potential for kind of like, beginnings or starting of invasions. So I think, I don't know, this is what I learned. It's just to keep in mind, if you see the adenoma going in that particular location inferiorly, there's a potential for an invasion.
And I think JP picked that up as well, actually, as he was looking at this, and you'll see the approach that he ended up using when we were there, Angela and myself and him in the operating room. But that's a good pick up. Go ahead, JP.
No, I was just going to mention that I'm sorry. I think it was Dr. Prasanna. First of all, I fully agree with Ala. That I agree with that. But I think it was Dr. Prasanna who was mentioning about the medial wall and the relationship with the oculomotor nerve. I think it's just a bit of I don't know. My anatomical interpretation is just a bit different. So indeed, if we look at the oculomotor nerve and the cistern there, we have the lateral wall, right? Of course, lateral to it, and then we have like something that looks like a wall right medial to it. But that nerve is still crossing through the roof of the cavernous sinus towards the lateral wall. So in this space here, even if we are to consider that there is some dura ring right medial to the oculomotor nerve, right there at this image, at this space, what is right medial to the oculomotor nerve is not going to be exactly the medial wall, even in normal anatomy. So in this case, the medial wall would be located, there is a small space, but like a real space medial to that nerve in normal anatomy, that will be the medial wall of the cavernous sinus. And if you look at the left one, it's just that I don't have an arrow to point that out. No, I'm sorry, the T2 one, but the normal left cavernous sinus. You'll have to scroll that a bit to the other side. Yeah. I'm sorry that I don't have an arrow to show, but anyway, so if when you go back to the right side and we see that space being occupied, it's the medial wall, at least in my interpretation, that is pushed medially by this tumor. Anyways, I think we can move forward, and maybe in the future we can have more images to discuss this. Thank you.
I want to point out also that is a beautiful MRI, Prasanna. By the way, it's got so many details, and this was a 3 Tesla, right? It's just absolutely gorgeous, all the anatomy that you can make sense, but all the nerves moving from side to side, the wall here, the wall not there, these are all these nuances that I think they become relevant into what we are about to do in the operating room. Go ahead, Ricardo, take it away.
Yes, sir. So the assessment is a pituitary prolactinoma with serious symptomatic hyperprolactinemia and severe side effects from the dopamine agonist. This is the CT scan just to see the anatomy of the paranasal sinuses and the cellar region. You can see here in the cellar region on the right is where the lesion will be there. You can see the septations towards the sinus, and that's important to keep in mind on your approach. I don't know if Dr. Prasanna has any other comments on the CT scan. Really nothing.
Well,
No.
what I would ask Dr. Donaldson, because Dr. Donaldson has the way they think from as an ENT, one for the approach, the drilling that she's going to have to do and things like that. Angela, any thoughts about this? Any teaching points for the residents at this point from your experience?
I think Ricardo did a good job. Again, for me, I'm looking for access and I'm looking for ruling out of infection. So the patient has a small mucocil or mucus retention cyst in that left maxillary. I'm not worried about that. I'm looking at the structure of the septum and the turbinates to see if there's any suggestion that I'm going to need to address that, because we want to make sure that you have proper access. I'm looking at that inner sinus septum of the sphenoid, seeing whether or not it's going towards a carotid or not, identifying, and again, go back just a little bit more, nope, the other way. There we go, right there. So this was one of those areas where the approach and the access was going to be a little bit challenging, because sometimes I don't need to drill out this large amount of bone. Sometimes I do. So we ended up, I think JP came and drilled a little bit more of that thickened combined inner sinus septum. I always tell patients, you got to think, or when I think about it, I'm thinking not only about access, but I'm thinking about reconstruction, because you have to be able, if you get a CSF leak, to reconstruct that area. It's almost as important as the access point. So in my head, I am kind of balancing how much access I need to give to whether or not I'm preserving edges of the bony wall, whether or not I'm preserving the floor of the cella, because those are the things that if there is a CSF leak, I'm going to need in order to make sure the patient is safe after they've had their prolactinoma resected.
Thank you. So the plan was for endoscopic transnational transsphenoidal approach with alternatives now in medical management, transcranial approach, radiation therapy. And this is a surgical video for the interest of time. Dr. Donaldson, would you like to comment on the ENT aspect and approach?
Sure. So in this patient, he actually had a little bit of turbinate hypertrophy. So what you're seeing is my access and reduction of his turbinates, which I refer to kind of like a liposuction. This is injection of acetylpalantine foramen, and I do that intranasally. Some people do it through the mouth. This is the posterior septectomy access, and what you're seeing now is sphenoid rostrum. I'm drilling down the sphenoid rostrum with the Sonopet, which is what you see right here. And that'll give me access to that inner sinus septum, which you see me drill. Once you get closer to the posterior wall, you've got to remove the mucosa so I can see a little bit better. And this is us kind of drilling out that broad-based portion that combined at the inner sinus septum.
Thank you. And Dr. De Almeida, would you like to comment on the neurosurgical part?
Yeah, so basically, those are just some of the anatomical dissections of a paper that is actually coming out next week that is just accepted by us. Basically, this is just showing, like, when we're thinking about the cavernous sinus, this, of course, it shows the left side, but we were thinking on the right side. Then we need to start looking at not only the paracellular lesion, but we often have to expand our approach to the inferior lateral component so we can access this anterior space of the cavernous sinus located inferior to the horizontal segment of the cavernous ICA that you can see on the left image. And then here you see that so-called medial wall, MWCS here. And if you displace the pituitary gland, you can see that there is really this dural tissue separating those two spaces, and that we're going to need to address. And in this case, it's a good highlight for this. You can go to the next one. And then here, yeah.
Oh.
You can go to the, and then that's just showing like some of the components of the medial wall. You can go. And then basically it's just showing like some of the spaces within the cavernous sinus that we suspected there we would find tissue there, especially in this area above the horizontal cavernous carotid, so above it and going towards the roof of the cavernous sinus that you see on figure C, and then also behind the ascending segment of the cavernous carotid, that here on figure C is still covered by some bone that we removed in the case as well. So you can go to the video, Ricardo. Thank you.
And maybe a good teaching point right there, and keep the video playing, Ricardo, but I think that you're going to see beautifully how JP is going to come in as he was showing the anatomy, especially when the anatomy is not extraordinarily distorted by a tumor, like in this case, because this is not a hard tumor that has pushed the carotid laterally. So he's coming inferiorly, attacking it from the safest angle. You know, look at that. He gets into the normal pituitary right there. He begins to dissect, and now he's coming laterally, inferiorly, you know, and you can see that nice minimal angle 20, yeah, softened right there. He pushed it a little bit, he knew, and then he's flicking a little bit. So this was about an hour and a half of work. This is not a trivial thing for us to give it a chance of curing this patient. You know, but it was a beautiful dissection, and and of course, Dr. Danielson is making sure that the endoscope is moving around. The window is very narrow right there. Keep going, JP. Tell them what you were doing right here.
So basically, we could see that when we opened the door of the cella, that we found no tumor. We just saw the normal pituitary gland. And then we saw that expansion of the cavernous sinus. We opened the cavernous sinus using that nerve hook, and then we had to cut the medial wall to create space, and then to use the flow seal to control that. Once we did that, we could see the tumor straight right in front of us, and then we start here just opening and expanding this anterior wall of the cavernous sinus, and here just removing some of this most anterior part of the tumor. Then we can work with the suction, and we can go all the way back. And then to further expand this opening, you can open all the way to the distal dural ring. Here we didn't go all the way up there, but we could, with maximizing that, we could mobilize the pituitary gland more. And then we start to see, we can start to see the carotid within the cavernous sinus. So the image is a bit dark, but we have the ascending segment of the cavernous carotid on the right side, and we have some tissue here right posterior to the pituitary gland. And what you see on the right side is the ascending segment of the cavernous carotid. And then we also had a part showing the cleaning of the roof of the cavernous sinus. I don't know, maybe Ricardo edited that a bit. But here's just expanding that opening towards the most inferior lateral segment to fully expose the carotid on that side. So we could clean behind the carotid. We also clean above the horizontal segment of the carotid. That part I think was edited a bit for the sake of time. And then we got a very satisfying resection, I would say.
I think that is important. A little maneuver that JP was using right there that I thought it was beautiful. He was using two suctions coming from different angles and moving, because once again, you're working to a space that is the size of my little finger, and you have a camera ready that Dr. Donaldson is holding, and then and the instruments are touching each other. It's not like easy. Angela, can you tell the residents how you're positioning your endoscope at this point? Because you're getting feedback from us.
Right. So I think that's probably, it looks easier than it actually is. And when you're working with a new surgeon, it can be hard to figure out the cadence and movement. If you feel the instrument at all, you're too close. You have to stay out of the way. So the best place to be is kind of at like 10 to 11 o'clock over on the patient's right side. That's probably your most optimal location. But for best kind of flow is you're supposed to be moving with your surgeon, moving with your neurosurgeon in every aspect. He should not, or she should not be kind of moving through the nasal cavity without you kind of prepping either where they need to look or how they need to get access. So it takes a little bit of time to understand their needs, but really you should be thinking the way they think and showing them either what you want to see, what you want them to see, or what they're trying to see without them asking and without them bumping into you.
To me, it's a beautiful. I mean, people watch those shows, Dancing with the Stars, but to reality, to me, it's a beautiful dance. It is absolutely stunning, and that's what I said. It sounds easier than it is, but Dr. Donaldson is working, and she's feeling those instruments. She's moving her endoscope around it, so that way the instruments come in and out, and there's a cadence, there's a rhythm, there's a feeling. I mean, there's no difference than dancing, except that you're dancing with the instruments as they're touching each other. There's a beautiful dance. I mean, the case, when beautiful, you can see where we are navigating. We have the pituitary on one side, the carotid on the other side. We're right in the middle of the cavernous sinus. I mean, these are areas where people did not used to operate. Even when I was training, we didn't go into the cavernous sinus like we do today. And we can only do it because of, one, the technology, two, they understand the anatomy, but three, the fact that we have this expertise of surgeons like JP and Angela just dancing beautifully side by side. And the reconstruction, Angela, was absolutely stunning as well. Thank you. I saw that. I mean, can you just briefly tell them how you'd reconstruct, just spend a minute or so people understand?
Yeah, so it was a smaller lesion, but there was a small CSF leak. So ultimately, and more importantly than that, the carotid was relatively exposed. And for me, I'm more comfortable if there was something other than normal mucosa covering that carotid. So I did a middle turbinate free mucosal flap just to give it a little bit more kind of structure and thickness to it as it's healing. He had a septoplasty, so that was just the kind of structural repair that we do for that. And I put a blue marker there because you want to make sure that you put the proper side down, because otherwise you can get a mucocil forming many years later, and then just a little Duracell for that.
Beautiful. Good. Let's see how the patient did now with Dr. Sampson and her team. Let's see what we're able to accomplish.
This is the post-op MRI, and you can see the expected post-op changes. You can see here how they got into this area and resected the previously noted tumor right there. And I don't know if there's any specific comments by Dr. Vibude.
No, thank you.
Thank you. So let me see if this works, but Dr. Argento had dictated the result. Can you hear it? No?
It's very low, Ricardo.
Okay, well, this is just the H&E section where it shows a very monotonous cell population with rounded nuclei, and there's a little bit of variability in the nuclei, which is acceptable in this kind of tumors. And this is just the staining that are consistent with a prolactinoma. So diagnosis is the prolactinoma, and this is the follow-up lab testing.
Yeah, so this is the follow-up, like post-op day one labs, the 777. We don't have here the 446 that was right before he had surgery. So it was 446, and then after surgery was 77, and there was another one in the 80s. But this is still a really good response, and he's going to get a new prolactin level check today. So we'll see what it ends up being. But overall, like, this is really good. And we expected that some of the prolactin was slightly more elevated just because there was so much tumor that was being mobilized.
Good point, because
surgical
it
outcomes-
was, I was just gonna say, yeah, the prolactin was almost 500 right before the surgery, which I was surprised that it went that high, that fast when he was that low with the therapy. Any teaching points right here, Susan, for our team?
No, I'm just so grateful that you guys debulked this, and then we could use an extremely low dose cabergoline, not a milligram twice a week, but maybe 0.25 once a week. If we did determine that his prolactin was still mildly elevated, but it is a far cry from what he would had to been on in order to control that previously. So very grateful.
So the patient did
Excellent.
very well and was discharged on post-op day 1 with close follow-up. And if we have a few minutes to spare, I don't know if this is some literature just showing that almost half patients that are withdraw from dopamine agonists recur, and the optimal, and most studies say that if they are kept 2 years in the medication, they have a more chance of having a good control after withdrawal. In this patient, the patient didn't tolerate it for more than a couple of months, and this is just a paper from the group in Mayo Clinic Rochester that shows the surgical outcomes of medical failed prolactinomas. And you can see here, just for perspective, how many patients were included in each of the studies. This is a meta-analysis, and how many of them were resistant versus intolerant versus both. And you can see it's actually a fair amount of patients that they are intolerant to these medications, and they undergo surgery, and out of them, 62% achieved remission with additional medications, while 38% only with surgery alone had remission.
Right, but in this, I believe in this meta-analysis, they included both endoscopic and microscopic. We have a series of over 65 patients from when I was in Houston, where with micros, we achieved around 95%, and with macros, with intention to cure, it was about 85. So I think those numbers get better and better and better in the hands of a skilled surgeon.
Yes, thank you.
Beautiful.
Dr.
Amazing.
Sampson,
Go ahead, Diego, please.
I was just going to ask a question. Dr. Sampson, do you think the cure is different for different hormone-producing adenomas, or is it not influenced by that, the rate of cure you see?
I think it can depend on, I mean, obviously it depends on the experience of the center and the team. I do think it can be challenging with the really tiny Cushing's ones because they're so tiny, and also the propensity of that patient to have a Cushing's tumor. Could there be more there, or why are they recurring at such a high rate? I mean, almost a 60% recurrence rate in those patients. And also, you know, extracapsular, being able to get around the capsule of it and avoid leaving tumor behind, or the capsule behind, the pseudocapsule, I should say. I think it's very dependent. I just think that because we have a medical therapy for prolactinomas, that surgery was really put to the side for many, many years. And now with advances in transfemoidal resection, I think we're revisiting that as a you know, multidisciplinary team.
And I would just echo what Dr. Sampson said. In the rest of the world, especially in developing countries, they don't have the luxury of being able to afford the medication. And that's still the gold standard, actually, to do surgery for these prolactinomas. And I think that now with these new surgical advances and more people from around the world training in the art of endoscopic dissections, going to the cavernous sinus, I think that we're getting better control of some of these diseases. So beautiful. Thank you, Dr. Sampson. I wanted to make sure that I think that this is next week. So I thank you, Diogo, for putting this Monday. So the mini toenail approach for vascular lesions technical nuances and surgical outcomes in a series of 680 cases. This is Edgar Natal. He is a giant in the world when it comes to this surgery. And he is a dear colleague from Mexico. He is the chief of the Department of Neurosurgery at the National Institute of Medical Science, which would be the equivalent at the NIH, but also is the chief of vascular neurosurgery at the Institute. And recently he is also been appointed one of the top leaders in Mexico for neurosurgery for the neurosciences, and he's a coordinator for neurosurgery for Medical Sur Foundation, which is a foundation that we partner with when we do our missions in Mexico. So we're looking forward to it. One other thing that I like to point out, I was telling Dr. Sampson, we record all this, and this is being recorded. I'm going to ask Adrian just to make a brief comment of what we're doing with this YouTube channel and all these pituitary cases that we've been recording over the years. Adrian, go ahead.
Yes, so good morning. Yeah, actually now we have a new YouTube channel of Neurosurgery Mayo Clinic, Florida. We have just finished to upload all the lecture series 2021, and they are divided into different sections. The oral exam, we have the keynote speaker, and in this case, lecture has been again divided based on the themes. So now we have just collecting the Friday ones, and we will do a similar work with the Friday conference. So editing the video and uploading all of them in the YouTube channel, when I have also to schedule a meeting with the fellows about to discuss better about how to catalog them. And so we're very excited about it. So we also invite you to visit it. I'm going to now send the link on the chat so you can subscribe on it. And please let me know for anything, because we're really available also to any kind of suggestions and help.
I was telling Dr. Sampson, Adrian, that it would be nice to have a small little video of her just promoting the pituitary portion of this YouTube, because we have how many? We're going to have several hundred probably or so of pituitary videos and these lectures, and so that'll be kind of nice, for us to do something. But we'll come up with some ideas. But yes, it'll be there. They're amazing, So good. All righty. Well, listen, have a wonderful holiday. Well, not holiday yet, but yes, sort of pre-holiday. We have resident interviews tomorrow. We're going to be interviewing all day. I think Kai is our residency director. So we're going to be in Mangurian, many of us, all day from starting at 7 a.m. until 5 or 6 p.m. So the residents, thank you, and all the fellows and people around the world visiting us today. So thank you for all your time and your dedication. And thank you, Adrian, for putting the link right there so people can subscribe. So, adios.